Greetings, everybody. It's great to see you again today here in mid-February. A much better time than the last time we talked, and that will be one of the themes when I speak about later. And it's really obviously great to see things improving in our community and across the country and really around the world right now from a COVID perspective. And so thankfully, we're able to return a little bit to what we've been trying to do at the end of last year, which is have these talks be much more about many of the other wonderful things happening at Houston Methodist. Where needed, we'll put some COVID in, so you'll see my remarks on COVID at the end. And we're actually giving Dr. Sussman a breather from being here in the studio this month, which is a really good sign because we don't have all that much new to report, which is good actually in this case. So today we're going to talk about cardiovascular disease and specifically in the realm of cardiology. And so we have two of our experts from the Methodist DeBakey Heart and Vascular Center, which is ranked number 15 in U.S. News and World Report out of about 4,500 hospitals in the country. So very proud of all of their efforts, along with the efforts of the cardiovascular surgeons and many others who help make that program function and work as well as it does. So we have Dr. Bill Zoghbi and we have Dr. Khurram Nasir here with us today. We also have Dr. Mon Malafki in the chat room, so you can actually ask many questions through the chat along the way. So I'd encourage you to do so, very similar to what we've done with COVID in the past, and that's always been a very popular feature. So now I want to introduce Robyn Canterbury. Robyn is going to introduce our physicians. Robyn is the chair of the Methodist DeBakey Heart and Vascular Center Council, and so leads up a group of volunteers who really engage us with the community and help steer the activities of the Heart Council, and we're deeply appreciative to her and all the members of that council for their great work. So without further ado, Robyn.
Good morning. Thank you so much for being here. Good morning. Thank you so much for being here today. Like Dr. Boom said, my name is Robyn Canterbury, and I'm chairman of the DeBakey Heart and Vascular Center Council. In 2013, my husband spent the better part of a week at Houston Methodist. It was a scary and overwhelming time for us as we had more questions than we did answers. About midway through his stay, a couple came into our room, introduced themselves, and told us they were part of the hospital's chaplain program, and they asked if they could pray with. They prayed for Embry, they prayed for his doctors, they prayed for me, and they prayed for our children, who at the time were very young. I have never forgotten how I felt in that moment, and Embry and I knew that Houston Methodist was the place that we wanted to give of our time and of our resources. Like many of you, we began with the society, and Embry and I have been on the Heart Council since 2015. Being able to learn about and support such amazing physicians as Dr. Zoghbi and Dr. Nasir have been remarkable and educational, to say the least. I continue to be inspired by our physicians who are not only innovating new therapies to help those who are affected by heart disease, and we all know someone who is, but they're also seeking ways to keep heart disease from happening in the first place. The Heart Council is an all-volunteer group, and our aim is to advocate for and support the education and research of the DeBakey Heart and Vascular Center. If this is something you would like to get more information on, please reach out to us. Our contact information will be given at the end of this session. Again, thank you so much for being here today, and I will now turn it over to Dr. Zoghbi.
Thank you, Robyn, and good morning, everyone. And thank you for joining us today. Robyn, I cannot thank you enough, you and the council, for the support that you have given the Heart and Vascular Center here at the Methodist Hospital. Your encouragement, your contributions, your engagement is very crucial to our mission to improve heart health and basically improve the lives of so many people affected with heart disease. And importantly, I think that we'll discuss today is how to prevent heart disease. It is so fitting today, Marc, that February is Heart Month. So I think more concentration on knowledge and hopefully application of the knowledge that we've accumulated over the years. So what I wanted to do in the next few minutes is to share with you some of the latest advances in cardiac care, and I encourage you to send some of your questions to us so we can help you navigate that may be at times daunting or more difficult situation. I'll share with you what our lens is when we look at phases of heart and vascular care. Yes, we think about diet. Yes, we think about exercise. Yes, we think about population health and the pandemic of obesity that we have in this country. We think about nature, and we collaborate actually with Texan by Nature regarding the effect of nature and lack of and pollution effect actually on so many things and heart disease. But also individually, certainly we want to partner with you as a patient, and hopefully not to be a patient, to keep you healthy. So that patient interaction with the physician and healthcare provider is very important, and using at the bottom there on the right the latest technology to diagnose and treat heart disease, so people can live with heart disease if they have it, but most importantly if they can prevent it. And I think this is very important for us. I wanted to share with you also that over the years we have had, all collectively with our community and our research, a major impact on cardiovascular mortality as well as morbidity. And these are some landmark things, and I'll share with you without you reading it, that obviously stenting, medications, cholesterol medications, blood pressure medications, lifestyle changes, so many things have really improved the overall mortality and morbidity of patients with heart disease, probably more than any other diseases that can affect us. Yet, and I would say yet, that heart disease is still #1 killer in this country and worldwide. And the statistics are sobering, and I'll share them with you. And the reason I want to share them with you is that we collectively can do something about that by treating it appropriately and preventing it in the most appropriate way. And I will go to the bottom one. Every 34 seconds, one American has a coronary event, and approximately every minute and a half, an American will die of one of the coronary events. So we could do something collectively. I'm glad you're tuning in today. Now, I wanted to share with you a cartoon here, which tells us something about heart, because heart is a complex. Yes, it is a pump. It's a muscle. But also you could see on the left side, these are the small arteries that supply blood to the heart, and this is where heart attacks can occur. Also, if you take a look at the right side, you could see the valves opening and closing. So yes, there are diseases of valves, diseases of the musculature causing heart failure. And you could tell also that the heart has a rhythm, its own pacemaker. So when the rhythm goes haywire and you may have atrial fibrillation or otherwise, we have to treat these conditions because they affect overall mortality and morbidity. Now, our approach at Houston Methodist is a comprehensive approach to cardiology. Having shared with you what the heart looks like and its function, we have to be able to image the heart in so many ways without reverting to a heart catheterization, and we'll do that mostly for interventions nowadays. So you think about interventions, valvular heart disease, adult congenital heart disease, electrical or electrophysiologic abnormality, how to treat patients with heart failure. We collaborate with our basic researchers, Dr. Cook, and certainly we want to educate the next generation of physicians. But also importantly at the top there is wellness and prevention, because we can prevent quite a few of these diseases, and I would say the majority of these diseases. So I want to share with you some of the innovations that we have in cardiac care. There is an explosion in cardiovascular technology and therapy, from imaging to stents, pacemakers, the way we monitor the heart. Even on your watch nowadays, you can monitor the rhythm. The imaging has improved so much that we can affect and image everything that we really need to do non-invasively, from the coronaries to the heart muscle to the chambers and everything else. And the right lower is actually prosthetic valves that over the past few years can be implanted without reverting to surgery, something that 10, 15 years ago was not imaginable. So in valve disease, one on the left side, there is a leaky valve. On the right one, there's an aortic valve that has a lot of calcification, doesn't open as well. It should open widely. And this is an area that we've done a major contribution in this field. These are various prosthetic valves to change these valves. On the bottom ones are the ones that can be done with a catheter, and we have been a leader in this field of catheter-based therapies. It is indeed an evolving world of catheter-based interventions for valvular heart disease. On the left side is an aortic valve that's been replaced. In the middle, a mitral clip. It's a clip that is put on a mitral valve and can be put on a tricuspid valve. On the right side, there are occluder devices. If there is a hole, if there is an issue there that can be done with an occluder device, yes, you can go ahead and do it. And we've evolved over the past few years into truly a structural heart program, not only here at the main campus, but throughout our system, to be able to provide these assessments as well as care for you. And it is indeed a partnership. And I'll share with you an example here. Take a look on the left side, that valve that was narrow. On the right side, this is the catheter-based intervention. The valve has been replaced without even opening the chest, and individuals can go the second day. They can go home the second day. Just imagine. Really amazing to be able to do that. These are therapies now for the mitral valve, and you could see a big leaky valve on the left lower end, and after putting a clip on that mitral valve, you could see that the leak in color. So much better than before. And we're involved in all the trials on the mitral valve, now replacing them, not only just clipping them. A lot of research and development is going in that area. Also, we're the first center to do trials on the tricuspid valve. It is the valve on the right side of the heart that at times can give you trouble. Also, we've been honored to be able to write the guidelines for prosthetic valves for the nation and international global audience and physicians. And I think we pride ourselves as being the leader not only in the research but also in the recommendations of what to do. Another area that has impact also on adult congenital heart disease with the leadership of Dr. Lin is that we could do 3D printing of a heart. And actually we have been the leader of this with a generous donation also from Mr. William Doré on our Heart Council. And why would we do a 3D printing of a heart? Because in complex diseases, I think it's important for the diagnostician as well as the surgeon and the interventional cardiologist to know exactly where the abnormalities are so they can address it. So on the left side is a total heart, on the right side is a mitral valve and the papillary muscles with it. It can really guide us into various therapies, and we are putting this into research as well as some clinical scenarios that really has helped us treat patients and certainly improve their symptoms. In the areas of arrhythmias and atrial fibrillation, major contributions here from our center. As you know, the heart has its own pacemaker. On the top is normal rhythm. You see that each one of these electrical blips is a heartbeat. It is regular. In atrial fibrillation at the bottom, the heart is very irregular, and that's one of the causes of atrial fibrillation, as well as it can cause certainly clots in the chambers, in the small chamber of the heart, and cause a stroke. So you have to treat it with medications, at times with blood thinners, etc., and with catheter ablation. I think our physicians here really are adept to this procedure. But what I wanted to share with you is some innovation that is truly has been transformational in the field of atrial fibrillation, is the one contributed to by our director of electrophysiology, Dr. Miguel Valderrabano. He dreamt about 13 years ago that there is a small vein, it's called the vein of Marshall, that you could see they are labeled on the left side, that actually if you can cannulate it with a catheter and maybe inject a small dose of ethanol to help the ablation procedure, that can not only prevent atrial fibrillation but basically keep these patients in rhythm. And from this concept early on to validation in the animal laboratory to a clinical trial that he convinced the NIH to fund. And it is a multi-institutional trial that was just recently published in the last year, and showing that indeed if you do such a procedure, you can improve the care of patients with atrial fibrillation. And I cannot forego and not mention the Texans actually have contributed significantly to his first pilot study by funding this pilot study, but also our council with their generous contributions to be able to do that before the NIH trial. So this is a team effort to be able to take an idea from a basic laboratory all the way to the clinic to be able to do that. And he's taken this actually to the ventricular side, not only the atrial side, to treat ventricular tachycardia and applying for an R01 at the NIH to do that. Another innovative thing that we're using to minimize radiation during these procedures is utilizing ultrasound in the catheterization laboratory to deploy some of these occluder devices that you've heard about and at times advertised even in patients who cannot take a blood thinner because of some contraindication. So I think these are important innovations. Heart failure and congenital heart disease, a large team of clinicians, surgeons, not only to perform heart transplantation and assist devices, but also to prevent heart failure, which I know Dr. Nasir will be talking about. Proud to say that we're number one in Texas from a volume of transplantation in Texas, number 6 in the nation from all the heart transplantation programs, and in the lower also amazing quality and prognosis for all these patients that have been treated. On the right lower, I'll share with you also that with our adult congenital heart disease team, we are the first program in Houston to provide transplantation for our patients with adult congenital heart disease. We've done 13 patients since last year, and that's really amazing. A collaboration also with our basic scientists, Dr. Cook, to look at reversibility of heart failure and recovery of function, which is, I think, is crucial for patients who have been afflicted with this disease. Another thing that I'm very proud of for Dr. Lin and his associates is to get funding from the Patient-Centered Outcomes Research Institute called PCORI to engage patients with adult congenital heart disease in their care and their information. So I think we're very proud to be able to do that by engaging patients because it is really a team approach. And last is cardiovascular imaging. It is really the core of all the interventions and diagnoses that you can think about in heart disease. From the early electrocardiogram to ultrasound to nuclear technology, cardiac MRI, cardiac CT, to tell us about the ailments and the early disease process in the heart. And I'm also very proud to share with you that we have 2 emerging national leaders this year. Dr. Little and Dr. Al-Mallah will be president-elects and president ultimately of 2 societies that will cover more than 25,000 members. American Society of Echocardiography, American Society of Nuclear Cardiology. Also happy to share with you that within the past 2 years, we were actually the first to have a PET-CT digital that arrived actually to Texas. We were the first in Texas to have that with the leadership of Dr. Al-Mallah. And within basically less than 2 years, we're doing more than 2,500 patients with PET imaging, PET-CT imaging, and a total experience of close to 4,000. Really amazing. And why would you need PET? Because it is the most quantitative methodology to take a look at how much blood is going to the heart during a stress. Number 2, it can tell us about viability of the heart, because if somebody had a heart attack, how much of the heart is still viable. Number 3, and this is unique for that nuclear imaging, is if there is an infection in any prosthetic material, in a prosthetic valve, in a graft that has been implanted, in a ventricular assist devices, this is the way to diagnose that indeed there is an infection, so our infectious disease collaborators can treat this patient in the best of ways. So this is truly amazing. And last but not least is a technology that is amazing, because if you think about the earliest involvement of the heart and the vessels with atherosclerosis, with cholesterol deposits, if you take a look at that graph down on the right, is if the narrowing of the artery is significant, yes, we can detect that with stress testing. So people who have some chest discomfort undergo stress testing, but we're only able to detect the significant ones, usually above 50% narrowing. But if you want to detect early disease and hopefully prevent progression of the disease, you need the earliest way of detecting it, which is, you probably heard about heart scan or a calcium score. And an arrow here on the left side shows where the calcifications are in the arteries, and we should not have any, ideally. So a normal score of 0 would be the best. Yes, it can increase with atherosclerosis, and particularly above age 70. And the higher the score, the higher the risk of a heart event. Now, how best to top that also with the recruitment, probably of the most famous person who has advanced the concept of the power of zero, meaning power of zero calcium score, the Dr. Nasir himself, who's joining us today. We were fortunate to be able to recruit him about 2 years ago. He is a well-known national and international investigator in the field of cardiovascular wellness as well as prevention. And I'll share with you that it was an opportunity that was amazing, really, Dr. Boom. He had moved to Yale 2 years earlier, and I thought that it would be very hard for us to be able to recruit him, just having moved 2 years there. And I sent an email just before our big national meetings just to test the waters and see if he would be interested in joining us. And indeed he did, and he said there's a headwind and there is a backwind. And the headwind is he was being recruited to another famous institution. So we accelerated the process with the help of Dr. Boom, and within 3 to 4 weeks, we were able to recruit him, and we're so privileged to have him here to head our prevention and wellness program. Khurram, it's a pleasure having you, and I'm glad to be here with you to talk about heart disease and prevention.
Well, thank you everyone joining today, and Dr. Boom for inviting to talk to this distinguished audience. And Dr. Zoghbi, what an amazing overview of the innovative care in managing heart disease at Houston Methodist. And I think so a great segue how we can shift gear from not only managing heart disease, but how to promote optimal health. As you saw, I'm also very proud, like Dr. Zoghbi, that our cardiovascular community has done amazing work that in the last 3 decades, we have significantly cut into deaths from heart disease to a point that maybe in the next 10 years, we may lose the stag that has been with us, the #1 killer disease in the country. But most of the advances that you have seen so far has been in better access, of course, excellent procedures, most of them that Dr. Zoghbi pointed out, and also implementation of the medication and reduction in the complication that comes along with this heart disease. But if you do a deeper dive, and what we have unfortunately not seen a major reduction in the heart attack. For example, if you look at this graph over the last 10 years, about admissions of new heart disease has at least nationally plateaued. Dr. Zoghbi highlighted about 650 new cases and some silent, about 150 silent heart attacks each year. The unfortunate issue is that almost 1 in 2 of these cases, or somebody who present with a sudden cardiac death, that is their presentation of heart disease. And although in this graph, as you can see across all the age groups over the last 3 decades or more, we have significantly reduced heart disease. On the very left 2 columns, you'll see among the young, we have not made those changes. And in fact, we are seeing this new trend, especially over the last 5 years, that many Americans under the age 60, especially now we're seeing under the age of 40 having heart attacks. Now, you may wonder why. Why haven't we been able to make those dents as we have done well in reducing folks dying with heart disease? And there are many reasons. I think so. I'll focus on a few of them. One is definitely our society has changed. We have now a more sedentary work as well as home lifestyle with less time for physical activity, more stress, poor sleep, compounded by a Western diet rich in calories and sugar. As a result, what we have seen this emerging burden, and I would say a tsunami of cardiometabolic disease, where in 2020, 1 in 10 of young adults are not obese but morbidly obese. About 1 in 3 of young adults have diagnosed hypertension. About 1 in 15 have known diabetes, whereas 1 in 4 1 in every 4 of 18 to 40 years of adults in US have prediabetes. So that's the number one cause. Number two is that we lack precision, and let me explain what I mean by this. So if you look at this photograph, who does this person look like? Actually, no one. This is an average of all the individuals across this photograph. So what's happening, especially in the cardiovascular prevention and risk assessment, is the way we identify those who are at risk and then manage is based on the law of averages. Unfortunately, you and I, we all know that no two patients are alike. And as a result, with this persistent focus on treating individuals based on averages, we are unable to help the right patient at the right time with the right intervention. And I can tell you that personally, I've seen it very up close. My father in the early 90s, in his 40s, had his first heart attack. Not a smoker, no risk factors, and actually he saw his physician almost a month back that told him that everything's all right. On the other hand, my mom, who's now 70, for the last 10 years, she has diabetes, high cholesterol, also suffers from arthritis. The physician's been adamant on treating her with cholesterol medications in spite of the fact that she has no atherosclerosis or the cholesterol plaque buildup in the arteries. So clearly we can do much better. Also, as Dr. Zoghbi has shown, that we have made significant advancements in the cardiovascular care. In the same lieu, especially in the last 10 years, the field of preventive cardiology has significantly advanced with our better understanding of what causes it, what are the better ways of diagnosing it, especially with imaging, and how we can come up with the personalized care for that. But this has resulted in some of the challenges, because now we have growing options, in not including only trying to figure it out what's your risk, but how do we treat them. There are many procedural challenges about getting the right medication. There is much more need for patient education, closer follow-up, managing their side effects, and helping them get to their goals where they need to be. Unfortunately, preventive cardiology is still left at the helm of primary care and general cardiologists that may not have not only the expertise, the bandwidth, and the resources to impact and help our patients where it's needed the most. So clearly, I think so we are at a great juncture in 2022 that we are realizing there is preponderance of evidence that an ounce of prevention is better than a pound of cure. Definitely living longer in cardiovascular health makes economic sense. And of course, the best time to repair the roof is when the sun is shining. However, nationally, there remains significant inertia in investment into the resources needed to support these preventive efforts. But I think that what attracted me to Houston Methodist was that the message from the leadership was clear and resounding that we are tired of the inertia. We're not going to wait for others to come and guide what to do. We will take charge in this. And I can tell you it has been a fantastic 2.5-year-old journey. Dr. Boom, Dr. Zoghbi, that what the message was, we need to take charge out here and create a resounding, top-notch program in the country with the same vigor that we provide our care. It's not only we're going to manage, but we're going to prevent heart disease for our communities. But not only that, but also become a hub for training and energizing the future generation in cardiovascular prevention, the art and the science of it, and leading the way by creating new knowledge in this respect. Now, all of this happening in the midst of, I think, the biggest crisis of our lifetime, if I may say. In other environments, I feel that prevention would have taken a backseat. But at Houston Methodist, I think it was the other way around, where there was more push for this preventive efforts. So in these circumstances, within 2.5 years, starting with a half-a-day clinic. Now we have a full 5-day fertile services that is meeting the needs of the patient, the only program in the country that does that. And we have a commitment to our physicians, our communities, our patients, all that they can directly even reach out to us, and we will ensure that they are seen in the next 2 weeks with a comprehensive risk assessment. We will not treat them by the law of averages, but have a personalized care and continue to hold their hands till we stabilize them where they need to be. Now, what our approach is different from many other programs that, as I told you, none of our patients are considered the same. Apart from focusing on what the traditional risk factors are, we utilize the extensive resources, possibly not at any other institute, the comprehensive imaging program, which is the focus of our risk assessment, but also going deeper with our translational experts into biomarkers and genetics, creating the wheel of, I would say, lifestyle management and tailored management that needs to happen. We have also created a checklist approach, learning from high performance industries in how to ensure that we are able to achieve those targets in a very short period of time. In this lieu, we are also partnering with our own employees, with Dr. Andrini's group, with population health, so that not only we are serving our communities, but those who deserve the most within our own family. I'm very proud to let you know that among all of this program, a population that we are targeting the most is the vulnerable individuals called with a condition, familial hypercholesterolemia, those who are potentially born with a genetic, I would say, defects that put them at risk of having a pretty high level of cholesterol all their life. Unfortunately, majority of them get undiagnosed till they present with their first heart attack. And as you can see in here, the risk of having a heart disease in this unique young population is even higher than those with established heart disease. And of course, you have the double whammy when you have them together. Now, it's a pretty complex management that entails genetic testing, cascade screening of their family members, a very dedicated lifestyle and medical management that entails from nutrition, oral pills, injectables, and at times even clearing the cholesterol from their body with dialysis. But most of this is guided by the imaging facilities and the imaging diagnostics that we have at Houston Methodist. And over the last 2 years, we have developed a very strong working partnership with the Familial Hypercholesterolemia Foundation that acknowledges our contribution in the fact that if you go to their website and are looking for help in Houston Methodist, our information pops up at the top. And in fact, over the last 2 years, we have seen more than 450 of these individuals in our system. Now, not only we are targeting those at the highest risk, but also unearthing many of the groups which were previously ignored but at a pretty high risk, such as sleep apnea, morbid obesity, a lot of the inflammatory conditions, and building dedicated pipelines with our physician groups out here to make sure that these individuals are screened, because they are at a pretty high risk of future heart attack and strokes, especially a 2 to 3 times higher risk of having a heart disease even before 60 years of age, and 3 to 4 times higher risk of dying with it. Of course, our core mission remains providing the clinical services and help to our community and our physician, but education is a big mission for us, with the goal of spreading the gospel of prevention all across the world. Among many efforts, we have, I would say, the top participating Cardiovascular Prevention Symposium, annual symposium that happens at Houston Methodist, where participation of more than 20 plus national and international renowned faculty. Last year we had more than 700 participants, and the next year symposium planning is also underway. And not only this yearly symposium, but with weekly training and guiding the residents, internal medicine residents, our own cardiology fellow, but also training the local trainers at Houston Methodist with lecture series and educational series right here from this studio once a month. Definitely 2021 was a major year for us with significant milestones. Of course, clinically, we have the privilege of growing our volume by more than 100% since 2020. But more importantly, serving about more than 1,500 new patients. And now speaking to my colleagues all across the nation, that is almost 2 to 3-fold higher volume than any of the more established programs, about 8 to 9 in the country. Research and development has been a major mission for us, and I just want to take a moment to express my sincere gratitude to Evan Katz and his family for their generous support that jump-started our program with more than $1 million in funding that has accumulated in significant acceleration of what we have done, accumulating in close to 150 high-impact publications, spreading the word in the best practices of prevention all across the world. We have been very fortunate using these resources to generate our first RO1 of close to $3 million, as well as attracting nearly $750,000 from industry for investigator grants. The program is supporting also one scholar career development, a young faculty, and also been able to showcase the work that we are doing that our community partners are also supporting, that allowing more than 22 trainees all across the level of sophistication who are getting these training with us. So now that I have shown all what we have done, and truly very proud and gratifying to see how far we have come along, I think we are not done yet. And the reason is, and we're still daring to be brave and reimagining the future, and that is happening because of the unwavering support from Dr. Zoghbi, Dr. Boom, but also ardent community supporters like you in the Heart Council, who is asking us to do more and push the envelope further. So for 2022 and moving ahead, we have 3 major initiatives planned. The first one is in our drive from moving away, guessing your disease and risk and who to treat at what intensity. I think so the first realization for all of us is happening as we have to acknowledge that data is the new oil. If you look all around us, while Google is learning with every click, and I think Facebook with every post, and Amazon with every purchase, and Tesla with every mile, unfortunately, as a healthcare industry in general, we've been a little left behind in leveraging these advancements, but not at Houston Methodist. With Dr. Sossman's leadership, 2.5 years back, there was a commitment for a big data and AI initiative that is being implemented all across the system. And leveraging that, we have built, at least for preventive cardiology and cardiology, a team of big data and precision medicine where we have access to one of the largest data archives and data sets in the country. And with this, we are combing every data point and trying to understand your genetics, your environment, lifestyle. And with the immense computational power that has been being implemented at Houston Methodist, and with our partnership, the goal is not only trying to identify who is at the highest risk, but also gain insights. What is protecting disease among who should have it and don't get it, so we can translate that into healthy aging. So that's our first big initiative for 2022. The second thing is that we are also trying to overcome our blind spots in cardiovascular disease prevention. Now, although I'm very proud of all the achievements, at the same time, we do realize that our gains have been unequal, especially in the minorities as well as those who suffer from various social risks. It's still unfortunate that even today in US, your zip code may predict more your risk and how you will do than your genetic code. And of course, environments is a big focus for us with the Center for Health and Nature. And at the same time, we are trying to say is not only keeping you healthy, but how can we also save you from financial toxicity that comes along with heart disease. In this, we are partnering with the Center for Outcomes Research. We have our own division of health equity and disparities research, and over the last year we had built the framework in how we can account for these social disparities, not only at the community level but coming up with a risk score at an individual level ready for prime time adoption within clinical care. So we'll keep you posted next year on our further advancements. And finally, the third biggest initiative is, of course, we are all realizing men are from Mars and women are from Venus. Clearly, there are gender and biologic differences that not only influence what causes heart attack, how does it progress, how is it managed, and the needs are clearly humongous. And as a result, Dr. Zoghbi and I have a full commitment in creating a center for women's heart health center here at Houston Methodist that not only focuses on prevention but all the other areas around cardio-oncology, your hormones and inflammatory conditions, heart failure and cardio ops. So keep posted. We are currently actively aiming to recruit a world leader in this space. We'll keep you updated on the progress. So again, prevention and wellness is becoming a major pillar supporting Houston Methodist transformative missions. We have come a long way, but we still have a long way to go. And what we have definitely realized that the same old thinking cannot be applied because it will result into the same old results. And the goal here is not only managing, but also preventing the upcoming tsunami of heart disease here. But for that, what will be needed, I clearly remember the remarks of Dr. Boom, we need unity here. And the unity is not only from our leaders at Houston Methodist, clinical, operational research, but also ardent followers, which I will and Dr. Zoghbi will continue to seek your wise counsel and support in this mission so that clearly in a few years down the line, we can take a look back and smile and be more proud of this transformative journey where we are making the shift from disease care to healthcare. As I was putting this together, Dr. Zoghbi, for me the redemption would be, and you've met my family, and that by doing all of this, I can at some point convince my daughter who still thinks that her mom is the smarter one. And I'm the only one who makes her favorite dishes and make her laugh. So thank you so much, everyone, for joining us.
Well, newsflash, I'm sure your wife is the smarter one. They all are. Mine certainly is. I think you see why we're so excited and why we got that introduction from Dr. Zoghbi about Dr. Nasir's arrival here, and now 2.5 years of significant impact. And as he talked about, he's put a big impact in a field that is as far removed away from COVID as you could be in many ways, right? And I think that's a really key theme because along the way, we've always said, we are going to care for patients with COVID, but we have to focus on all of the rest of illness that's going on. And of course, as we move in the future, we have to continue to learn how to coexist. And as many of y'all know, I'm a primary care physician, still practice a wee bit. So what he talks about is like music to my ears because, of course, what I'm trying to do is keep my patients and help my patients on their journey collaboratively and as a partnership to keep them well. So I want to kind of drill in on that, and we got a few questions ahead of time, and I'd encourage anybody to send in some questions. I know a lot of them have been getting answered in the chat, but I want to talk about cholesterol lowering because that's one of the big prevention areas, and we got a couple questions around that. Got a lot of very detailed questions. I want to start with a more elevated question. So cholesterol is one of those treatments that's guided by a lot of national recommendations, right? So there's sort of sets that keep coming out periodically over time. And for the last few years, a big change from very numbers guided to more risk of future illness dictated. But if you plug a 70-year-old into that calculator now, you'll put them on a statin. I mean, it's almost every person. And I think what I hear you saying is we need to be much more targeted than what the national guidelines say. So talk a little bit more about kind of cholesterol management, particularly for the people here, because we're going to have people running the entire age spectrum. I guarantee there's a lot of people on Lipitor or some other statin in this audience, but there's probably some others who need to be on them, and there may be some who don't need to be on them. So talk some more about that.
Sure. So, Dr. Boom, cholesterol's really, I would say, the foundational from the prevention perspective. And if you look at the history, cholesterol has come a long way. Actually, it was almost, I think so, less than 30 years ago, where as cardiologists, we didn't believe in the cholesterol theory. And if it wasn't for our own Dr. Tony Gatto, we couldn't have gotten to that point. And suddenly, I would say the spectrum moved completely to that it's all about cholesterol. Now, my journey in trying to understand cholesterol roles in the heart disease started almost 15 years back at MGH when two individuals walked in, one a 65-year-old male who had the familial hypercholesterolemia. That means they have this cholesterol 3 times higher than your normal cholesterol all their life, and his 45-year-old son. And the CT scan was the new thing at that time that we have adopted now here. And we scanned them, and I was pleasantly surprised to find that they have no underlying plaque buildup. And that really started the journey where we started looking at national data sets, and we came to a realization that in spite of the fact that yes, cholesterol is one of the main risk factors, not everyone is at risk. Almost about 35 to 50%, depending upon which age, do not have any plaque buildup, the coronary calcium score that Dr. Zoghbi pointed out. A lot of work from our group then also showed that you may be a 70-year-old male or a woman who has high cholesterol, or just based on the risk, a candidate for the statin, a commitment for life, but may have no plaque buildup. And you are protected for the next 10 to 15 years. Similarly, that could be a young and an older individual. So as a result, in 2018 and 19, the guidelines made a dramatic shift. And especially the recommendations are, if you're thinking about a statin, and especially if you're uncertain for these patients, think about getting a heart scan, which is, again, the foundational focus of our clinical care. And if you don't have atherosclerosis, you may be protected for them, and you can have flexibility. So definitely, as a result of that, almost about 48 million individuals in this country who are uncertain about statin therapy, you can get more targeted. It allows us to do 3 things. One, as a clinician, for you to have more personalized care. As a patient, it allows you the choices to make based on your values and preferences. And I also see the value at a system level where we can allocate the resources who need the most.
It's also important to differentiate primary prevention from secondary. If somebody had already a heart attack or a stroke,
that's a different.
It's a different
you need,
ballgame.
you need
the
that,
stat,
period,
yes.
right?
You need it. The primary prevention, meaning what does the future look like? Can we reduce your risk? And I think a multi-pronged approach. The beauty of, and there's a beauty and there is a limitation to these cohort equations that we talk about. It gives you a ballpark of where you are, but this is for a population as opposed to an individual. Sure. And this is where imaging can help you in addition to looking at statistics of such an individual. So I think, fully agree with you, but differentiating primary prevention from secondary prevention would be important.
Well, very, very, very useful. It's wonderful to have tools to actually better risk stratify. Unfortunately, a lot of the payers still don't necessarily always pay for calcium scores, which is a challenge. But it's a pretty inexpensive test.
It is very inexpensive.
So I know I use it pretty widely in my practice as well. It's been a really great tool. So I had a couple questions about cholesterol lowering that are very specific. And of course, I'll remind everybody, talk to your doctor about the specific medical advice. But we're going to give you kind of the education around some of your questions here. This one has to do about people who have muscle pain with cholesterol-lowering drugs, an issue for some people, obviously, with statins. Talk about what do you do with somebody like that? Can you manage through that? Can you change drugs within the category, or do you need to switch to some other kinds of therapies or other things?
So from a cholesterol management, I think so when we're thinking about muscle aches, there are mostly limited to one class, which has been the most prominent one, which is statins. Now, as Dr. Zoghbi pointed out, of course, if you already have an established heart attack or a history of stroke or blockages in your leg arteries, then definitely the goal would be to try to lower your cholesterol as low as possible, either with statins. And if you're unable to tolerate it, which is about in 10 to 15% of the general population, thankfully in 2022 we have multiple options already FDA approved, have shown benefit, that includes 2 oral pills. One it's called ezetimibe, the other is bempedoic acid. And now we have 2 injectables that you can use it twice a month, or now there is a new innovation in this space where you can use it once every 6 months, but it has to be implemented within the office setting. So the good news is we have multiple options. In this scenario that you do not have an established heart disease, I would strongly suggest also considering getting a heart scan that can give us insights if and how aggressive we need to be. There is quite a possibility that you may be able to avoid, at least in the short duration, statins or other cholesterol lowering just by focusing on the lifestyle.
So a person like that has a high cholesterol, they didn't tolerate statins. If you get a heart scan, it's 0. You probably can tell them you're okay for a while. We'll need to monitor you in the future. What about a heart scan? What a heart score? The calcium score of 1 or 2, something really small but not 0.
So for the heart scan, and then again, this is the entire spectrum, and that's where the age comes into play. So if we have a 40-year-old and we're seeing very early atherosclerotic disease, especially if you have a family history, a score of 1 is pretty high for your age and gender. We definitely advocate very aggressive lipid lowering management for them. So if they are unable to tolerate, then we move on to these additional options. Thankfully, all of them are available. We have to go through some of insurance prior authorization, but the teams are here to hold your hand in that direction. The second piece is if you are 65 or 70 and have a calcium score of 1, studies now have shown that maybe you can be flexible in that group, but not the young ones.
Great. So very age dependent,
Yes.
and of course some other risk factors and things. Another question we got was about somebody it looks like had some issues, they say, when they were on a statin, which increased their creatinine levels, and asking about that.
So again, the major risk is the muscle aches, but we do see individuals coming with a creatinine. The strategy is this.
To be clear, tell people about what creatinine is.
Sorry, the creatinine is a marker that indicates how well your kidneys are functioning. So sometimes it can affect the kidney function, not as common side effects. We do often see an increase in the liver enzymes, suggesting that you may have some early harm in that. Now the strategy again, Dr. Boom, remains the same. If depending upon if the person had prior established heart disease, a stent, a stroke, a peripheral arterial disease, then we help them move to these additional medications. Definitely we would like to get their bad cholesterol less than certain amount, drop it by 50%, or getting it less than 70. What we have seen significant success by the injectables, which is a new class called the PCSK9 inhibitor. Definitely would strongly advocate that if you are unable to tolerate statin, look for those targets. However, if you're lucky and you do not have an established heart disease, then based on shared decision making, getting a heart scan can at least guide you and your physicians. How aggressive do we need to be? You may do well with a small dose of a non-statin cholesterol pill, or do we truly need to be aggressive and get your LDL below a certain number like 70, or if you have extensive disease, these days we are going even below 55.
Fantastic. Well, thank you. Well, I'm going to shift to you, Dr. Zoghbi. We got actually a couple of questions, some specific ones about some specific rhythm issues. Somebody would like to know a little bit about treatment and management of bradycardia. Well, slow heart rate.
Yes, bradycardia is a slow heart rate. By definition, it is less than 60 beats per minute. But that can be physiologic. The question is a few things. One, heart rate changes all the time. If you check it now, if you check it 10 minutes later, a little later, it'll be different. If you're excited, it may go up. If you're concerned, it may go down or up. At night, it will go down significantly. It may go down to the 40s and at times even in the 30s. So we don't measure it all the time. And nowadays with portables, with all these wearables, you may be much more aware of these changes. So one, be cognizant of that it changes. Two is, if it is consistently low, like in the 50s or so, it may be still physiologic, meaning it may be normal, particularly in an individual who is very athletic. So if some of you pride themselves at being athletic, heart rate would be low. And I think most athletes would do that. So if you swim a lot, run a lot, and other things, that could be physiologically normal. So you can have much more reserve when you exercise, etc. Obviously, also, if you are on some medications like beta blockers, it will slow down your heart rate, and that's by design and by properties of those drugs that your physician has put you on. Now, the question is, where's the concern? The concern, if it is very, very low and you're symptomatic, meaning you don't have energy, at times you're maybe almost fainty or passing out, you have to be careful about that. At times, there are also rhythm disturbances that are of concern. So you need to check with your physician and see, is it because of an electrical abnormality in the heart per se? And nowadays there are amazing monitors that can monitor your heart, more sophisticated than your watch itself, can monitor it for 2 weeks, a month. It can monitor it even for a full 3-year period if it is put under the skin. So we have so much technology to be able to do that, and always check with your physician. And at times, maybe with a cardiologist.
So say you do have a low heart rate that is very symptomatic, it's problematic, it's not because you're on a beta blocker, it's not physiologic. What are the treatment options? What kinds of things would you do for that?
I mean, there are stimulants at times which may increase heart rate, but most of the time we don't use them. And if it is very, very low, I think a pacemaker, or at least checking with your physician and see if a pacemaker is needed. If you're very symptomatic and for whatever reason you have what's called chronotropic incompetence, meaning heart rate doesn't go up because of a pacemaker issue that we may have.
Great. So if your own pacemaker's not working, we put in a pacemaker, basically, is what you're saying. Okay, great. Well, so also another rhythm question actually was directed to you, Dr. Nasir, which is around atrial fibrillation. Obviously, we hear a lot about it. I think I see a commercial every day during the Olympics on something around atrial fibrillation, among many other things. Can it be reversed? I guess first off is the question with lifestyle types of changes. And I will add also, kind of in your realm, can it be prevented so that we don't get older and find out one day we have atrial fibrillation?
So again, atrial fibrillation, Dr. Boom, doesn't come alone. It comes hand in hand with a lot of the cardiovascular comorbidities, especially with poorly controlled hypertension, obesity, poor exercise, and now we're seeing a major contributor, which is in combination with metabolic syndrome and all of this coming, sleep apnea. So once you have atrial fibrillation, usually there are two pathways. One is in trying to control the heart rate or converting back to a normal rhythm, either via an ablation or giving you a shock, with the goal of keeping you in a normal rhythm. Apart from management, the four things from a vascular prevention are key here. Number one is ensuring that sleep apnea is diagnosed and managed. Now we are seeing significant improvement in reduction in the recurrence of this atrial fibrillation by weight loss, as well as with dedicated exercise regimen program and hypertension control. So our program supports our EP group where these individuals are managed. Now we have excellent weight loss medications that can also help in this. Now talking about the prevention, absolutely, it's not only about preventing cholesterol plaque buildup in the arteries, but also I think our biggest dividends and gains are in prevention of early heart failure and AFib, and hence the focus on blood pressure control early on, weight management, exercise, and of course planning and treating obesity if it exists, especially in the young population who are morbidly obese.
So picking up on the hypertension theme, since that obviously is a key factor, every time we look at data around hypertension at a population level, and you talk about population health, it's pretty lousy, right? I mean,
yes.
People's hypertension is there. Some of them are treated, and a lot of them are in, either not identified, not treated, or identified but suboptimally treated and really not getting the benefit they should. How are we going to change that? Because that's been a persistent problem for a long time. It seems to me there must be technological solutions, healthcare structure solutions to address a big problem like that.
Right. So blood pressure is a very challenging, and something like heart rate, it changes depending upon when and how you're checking that. Of course, our definitions of hypertension have changed. Now we think the diagnosis is if your top number is more than 130, previously it was 140. A significant proportion remains undiagnosed, and even if they're undiagnosed, undertreated. Of course, the changing structure of sedentary lifestyle, obesity, Western food is not helping at all. So from our perspective, what we are trying to do is have a very comprehensive approach rather than focusing on what is your office visit blood pressure, do a home monitoring. Now there are devices, actually a lot of the sensors are able to give us the blood pressure, guiding us whether that number, where the numbers is, and then a more closer follow-up with the remote monitoring help us titrate the medication and trying to get the numbers where they need to be. In general, if you are higher risk, for example, have an established heart disease, you have kidney problems, diabetes, or you have significant amount of plaque buildup, and Dr. Zoghbi, we are also employing a lot of the imaging techniques to identify the earliest heart damage before we have a full-blown heart failure, because if you can identify enlargement of the chambers or your heart's not relaxing as well as your muscle is thick, those are the top risk factors for heart failure and AFib, and targeting those individuals and getting their blood pressure down to an optimal level will significantly cut back into the risk of having a heart attack, heart failure, as well as AFib.
This is really the lowest hanging fruit. Blood pressure is, and at times, I know patients are concerned if they take more than one medication, but they need to know at the same time that we know that from population studies that if you have truly hypertension, you're going to need at least 2 to 3 medications to control it well. So if you're already on medication because of that, might as well control it well so we decrease the risk. And the control is a systolic below 130 and a diastolic below 80 the vast majority of the time. Yes, you're going to have few blips, but vast majority of the time. And going back to obesity and sleep apnea, this is one of the causes of hypertension. So you need a good night's sleep to get down your pressure at the same time, and know your numbers. Each one of us needs to know what their blood pressure is, what their sugar is, their weight, cholesterol, and all that. Know your numbers.
Well, great. Well, that's very, very helpful. Thank you. I'm gonna end with 2 questions. One I'm going to ask both of you, because you touched upon the fact that in spite of absolutely amazing progress over the decades, heart disease is still the #1 killer. It's much narrower gap now with cancer as the #2 killer, but it is still #1. You, Dr. Nasir, said it may not be #1, maybe at some point in the future. How long before we get to there? What do you think?
Actually, if you look at the numbers, and these are national statistics every year, they come from the American Heart Association, we're neck and neck in the United States. In the world, if you take a look at the world, number is by far still a major #1 in the world. And it is mostly because of access and paying attention to the major risk factors of heart disease, truly. That's why I said at the beginning, in the vast area, it is preventable, because you can prevent higher cholesterol, blood pressure, heart attacks, heart failure, which are conglomerate, and also atrial fibrillation, a conglomerate of your major outcome. So what we have in the United States now, we have over the past 2 to 3 years a leveling off of that nice diagram that I showed you, and actually maybe an uptick in it. And this is because of the epidemic of overweight and obesity. We have 2/3 of our population above the usual weight, about 1/3 obese and 1/3 overweight. So, and that will combat everything else that we're trying to do with medications and everything else. So take a look at actually all the components and also availability of care to the various populations that we have. And the last study looking at this, about only 60% of our population in the United States have their blood pressure where it should be. Just 60% with availability of everything else. So just imagine how much more you can prevent heart attack wise, heart failure wise, as well as stroke.
Well, thank you. So, one of my favorite sayings, y'all have probably heard me say, is when the hospital systems compete on unparalleled safety, quality, service, innovation, patients are always the winner. There's lots of other things like population health, from disaster planning, from research education, where when we collaborate, patients are the winners. So I want to lay down the challenge. I want a competition between our cardiologists and our oncologists to say, okay, we're both going to drive this down, and we're going to try and race as low as we can. How's that? So, because it has been phenomenal in both fields, as what we've seen, but particularly in heart disease. So I'm going to transition now to a little bit about COVID. So as a transition, before I let you two off the hook, we did have one COVID-specific cardiac question, which is, how is COVID affecting children ages 16 to 21 who have underlying cardiovascular issues?
First, let me refer you to actually a publication from the DeBakey Heart Journal about COVID and the heart. And this was just published in this past January. So I think if you need as much information as possible, I think I would refer you there. Remember a few things. One, there are many risk factors for COVID affecting overall health, lung as well as heart. Age is one, but also the young adult is not completely protected, although they're at a younger age than in their 60s and 60s and 70s, particularly if they have other comorbidities that we know can affect outcome, such as obesity, which is still prevalent, unfortunately. They may have some heart ailment. Heart failure at times can occur in the young. They may have valvular heart disease. They may have other issues. So I would be as protective in these individuals as much as the individual with the highest risk. Yes, it can affect the heart. Small percentage of myocarditis, pericarditis of less than 1 in 100,000. So yes, it is very small in a way, but I think we have to protect all of our individuals from what is going on in COVID. And we have all that at our hand now.
Well, thank you both for really great discussion here. It's really nice to be able to talk about cardiovascular health, and I hope it's helped each of you and hopefully some inspiration for some prevention and avoiding much heart disease in the future. I'm going to shift gears now to an update, really focused today on COVID. As I said, we gave Dr. Sussman a breather because things are going in the right direction, and it sure is a lot better to be here than it has been over the last couple months, where all we're talking about is things going in the wrong direction. And so, very pleased with what I'm seeing in the community where things are going. So I want to follow on a little bit with what we talked about last time. If you remember, we talked at length about, well, why has the U.S. been so much worse experience from hospitalization, particularly death, than other countries, particularly the UK. I will say, if you look at this, we have basically paralleled what's happening in the UK, slightly behind them, because our peak was a little behind them. And in fact, at this point, our numbers are actually down lower than the UK. Now, remember, one of the things I showed you last month is they do way more testing than we do. They have better infrastructure for that. So I always take those numbers with a little bit of grain of salt. But as you can see, we have come up and we are coming down very, very sharply. And in fact, if you look at our community, the thing I look at the most now is either our numbers, which, of course, are going to be a little lagging because I'm mainly looking at hospitalizations. And then I look at the wastewater, which tends to be a pretty good, close to real time. And I say close to real time because we get it on Monday from a Monday before. So it's always at least a week behind. So right now, the last number you see on here is not from 3 days ago, but from 10 days ago. Remember, they benchmarked this against July 6th of 2020, which was the peak of that first bad summer surge we had, and the amount of virus they saw in the wastewater. Two reasons virus goes up, either more people have it or the people who have it have more virus and are shedding more virus. And what we saw with Omicron is probably a combination of both. And you can see it shot up very quickly and very steeply. They've readjusted some of the numbers. I don't quite understand all of their week-to-week machinations on that. So the peak's a little lower, but nonetheless, nonetheless, the directionality is what really matters here. And what you see is we're now down to 126% of where we were in July 2020, right about where we were when Omicron started launching. Not nearly as good as we were in October, November, where we'd gotten down to about 80%. Now that was all Delta. This is Omicron, which is a little milder. So we are entering a very good period here. I mean, this is circulating at much lower levels, but still circulating, let's be clear. It's still 126% of where we were at a peak previously, but now with a, highly vaccinated or highly, highly immune because of previous infection population, and probably, as we've talked about, a milder variant. So we're entering a much better period of time here. And in fact, you see that in our numbers. We aren't done yet. We are still 350 plus people in-house, but that's a heck of a lot better than 800. And, coming down, not every single day and not as rapidly as we would like, but coming down nonetheless. And in fact, I've shown you this before. This is Delta versus Omicron. The blue line is positive tests during Delta, which led to the orange line, which was the census in the hospital, which when it got to peak, it stuck there for about a month, which was, that was kind of most of the month of August into the first few days of September. Very challenging because of its duration and its severity at that point in time. What we saw here is that gray line is the number of tests. It shot up. It's coming down. It's not coming down quite as steeply for the people we see at Houston Methodist. This is our testing, but it's leading to that gold line of the census. And what you see is that shot up pretty quickly as well, although not quite parallel, which was, thank goodness, because this would have been way out of control. It peaked, held on for a while, but started dropping a little more quickly than the last surge, thankfully. But it's still not got as steep a slope as we'd like. So we're still, dealing with this, still have a lot of patients in-house with COVID. Again, a caveat that some of these patients, not, but nowhere near a majority, some of them have more incidental COVID at this point, but still many, many people with COVID. But as you can see, going very much in the right direction. Unfortunately, as we talked about last time, this has still resulted in a lot of death. This is the curve of patients, a 7-day average of getting admitted in the orange line, for all, starting with actually surge 2. So this is June of 2020. And then the blue line is the 7-day average of the number of people who died. So the worst wave for us was Delta this summer, where at peak we had 14 patients or so a day on a 7-day average. So that's 100 people a week dying. We peaked out at about 10 and a half this time, and we're down to about 6. So things are a lot better, not done, and unfortunately there still will be some death. But I'm also heartened by the fact that there's a little less lag if you look at the data here. So I'm hopeful we'll continue to see those numbers come down pretty sharply. This is a nice analysis from the Financial Times. They've done a series of pretty nice, kind of lay people analyses over time. Infection fatality rate's always been sort of the holy grail of what we want to understand, which is if one person gets infected, what's their risk of death? And it's always been hard to calculate because we don't identify every person who's infected. There's lots of asymptomatic illness, etc. And so take this with some grain of salt, but their best estimate as sort of what has happened to the infection fatality rate throughout the course of this pandemic. Some of this is a virus that's gotten a little milder. A lot of this is, of course, vaccines, and you can see it going down pretty steeply post-vaccines. And a lot of this, of course, is now, if you haven't had a vaccine, you're more likely than not have at least some degree of previous infection. And their estimate, at least now, is we're still dealing with at least twice the infection or the fatality of the flu, but we're not talking about 10 or 20x the fatality of flu. So that has to inform how we act and how we behave going forward, obviously assuming this hangs on. Unfortunately, as we saw, things can change quickly. We feel like we've dealt with the variant of the month. For most Americans, they woke up Thanksgiving Day or the day after Thanksgiving and sort of saw the news and said, oh, crud, right? And we'd seen it a little bit, not much earlier than that in the health area, because it had only showed up in South Africa about 2.5 to 3 weeks before Thanksgiving, and really was exploding out of control those last few days before Thanksgiving. 3 weeks later, 90% of our samples were Omicron, and then of course we had the surge that we saw. And there's a lot of chatter out there now about the BA2 variant. It's not been given another name, so it's almost, I consider it almost a sibling of Omicron right now. It could end up with another name. In fact, in some areas it looks to be out-competing Omicron. So if you look at the country of Denmark, for example, it kind of has extended their curve and ended up out-competing. I will say, we've now done well over 70,000 genome sequences of virus at our institution. When we saw that one coming, we basically said, okay, we're a little backlogged because we were seeing so many cases, but they were all Omicron. And so we accelerated forward, said, let's get real-time data. And we have very real-time data. The last ones came off the sequencer just a couple days ago. I think they do 768 samples on the sequence. About 9 or 10 are coming in as BA2, and it's been that way for a couple of weeks. So we, knock wood, at least have not seen any change in our community where it looks to be out competing. It doesn't look to probably be more severe, just looks to be a little more infectious than the Omicron variant. So we're crossing our fingers this won't be a problem here right now with the data we have. It does not look like it will be a problem here, and we continue to go down, but it is an area that needs to continue to be watched. CDC put out a little refined guidance around who should get tested. I just put this up there so you have that in your materials. Kind of useful. Obviously the availability of home tests is back up, so you can go get those pretty easily now. I keep a whole stack at home, and anytime we have any question, we still test, and somebody gets tested. Certainly if we're going to be around somebody we want to protect that's at high risk, it's still a very useful strategy, something you should titrate up and down based on your own risk and based on what was the risk in the community at that given time. A couple of key updates. Moderna is now fully FDA approved, just like Pfizer was a few months ago. What this means logistically really is that any physician can write off-label prescriptions for Moderna just like they can for Pfizer. So we get many, many questions around, should I get a fourth dose? There's no clear-cut answer to that. Certainly if you're high risk, as we've talked about before, and it's 5-6 months after your booster, it is a reasonable thing to consider, and many physicians have been prescribing that. But that, again, is a conversation between you and your physician, and really the only legitimate way to get that done is through a prescription. You could probably pull it off if you went to a drugstore or went to a couple of them. You'd probably pull it off yourself if you wanted to. But a fair conversation for you to be having with your physician if you are a higher risk individual and getting farther out from your last booster. Children, obviously a very hot topic. So many parents, are almost desperate to get their young children vaccinated. Obviously, we have 5 to 11 was the most recent group, and we were all sort of expecting the 2 to 5 year old age group. Or even the 1 to 5 year old or 6 month to 5 year old, somewhere in that range, age group to get approved. In fact, the FDA had been kind of nudging the companies to move forward, but last week actually, and I think this is our processes working, they said, listen, we don't think we have enough data yet. Not around safety. The safety profile looks excellent. What they've seen is the 6-year-old to 24-month-olds were having an antibody response. But the 2-year-old to just under 5-year-olds that are in the study were not having an adequate antibody response. Now, they give like a 3 microgram dose, so it's like a tenth of what they're giving to adults. So it may be dose related, it may be needing for another dose, and so they are still studying that third dose. And so the idea of sort of, I think, approving that 6 to 24 month, but not approving or approving without the data, the 24 month up to almost 60 month, I think caused them to say, let's wait a little longer, let's get the data in place. And so I'm still hopeful this will happen, but we want them to obviously have the data that supports the use of it in this age group. The other age group then is the 0 to 6 month, which we're not going to see vaccines anytime soon, if maybe ever, I don't know. Study yesterday in the New England Journal of Medicine, it was too late for me to throw in here, but I want to make you aware, that showed 61% protection for 0 to 6 month olds whose mothers were vaccinated during pregnancy, and of course who are breastfed, because that's the only way you would pass on those antibodies. And so that's really significant protection. And in fact, for mothers who were vaccinated in the later parts of pregnancy, it was as high as 80%. Probably, I'm going to guess, because they have more circulating antibodies like we all do early on after vaccine, and those are being passed through breast milk. So, again, protection of newborns in a very young, vulnerable age can happen through vaccination of the mothers. So with all the discussion around should we vaccinate pregnant women, you've heard our obstetricians time and time again urge that pregnant women who are themselves higher risk, this is yet another reason for pregnant women to get vaccinated. Some really good news, which is as of the last day, we have loosened the criteria for utilization of sotrovimab, which is the one monoclonal that works against Omicron. We just weren't getting enough, so we had to put it there for the highest risk people, which is the tier 1 you see on this slide, which was really either very immunocompromised or older. And now with tier 2 opens up to a much broader group. Still not every single person who's qualified under the EUA, but the vast majority of people who would need this now. So that's great news. And that's a combination of supply coming up and demand going down now as we're in a better place. And then the other news is another monoclonal drug is now coming out, and we expect to have it within a week or two, that is active against Omicron. And so you're going to see that kind of supply chain populate itself. And I'm hoping that the federal government and others will have stockpiled enough that, if we get another variant, that we have more of this societally available. I think you're going to see the same dynamic when you talk about Paxlovid, which is the main drug that's out there that we think that looks really promising and has been used now, but has been in very short supply. So hopeful that if God forbid we get another variant, hopefully these monoclonals work and we'll have a stockpile. Almost certainly, but based on most experts, the Paxlovid will work and we'll have a stockpile that's built up societally for that, which would change the dynamics, obviously, a great deal. I want to wrap up with just an additional piece of data that came up around boosters. This graph here on the left shows individuals who either are unvaccinated in that top line, which is the kind of black line. In the dashed light blue line, that's individuals who got a 2-dose series. And in the dark blue line at the bottom, that's individuals who've been boosted. And what you do see is clearly we saw more infections, right? We all knew things broke through with Omicron, but still the risk of infection dramatically higher if you're unvaccinated. And remember, they're not parsing out unvaccinated and had a previous infection, unvaccinated, has never been infected. This is all unvaccinated. So within that, there are probably some people that are on a little lower risk than that, but there are some people who are probably way higher even than that. And so that is obviously of great concern. But most concerning when you look at the right, that is death. And the death rate for unvaccinated consistently has been dramatically higher. And in fact, if you look at the blue box on the bottom right, if you are boosted, well, if you're, let's say it this way, if you're unvaccinated, you have 68 times the risk of death as if you are somebody who has been vaccinated with a 2-dose series and received a booster. 68 times. I mean, it doesn't get any clearer than that. And so, of course, we continue to push for boosters. I honestly, I said this to you before, I've kind of given up a little bit hope in getting people who've never been vaccinated, but there's a whole heck of a lot of people who haven't been boosted who can cut their risk from about, 1/15th to maybe 1/7th. So they cut their risk by another 5-fold by getting boosted. And so please, if you haven't, get boosted. I will say our numbers are starting to get pretty low, and so starting beginning of March, we are actually going to go down to just the Josie Roberts site for vaccines and shut down the hospital-based sites around the city. There's just not the demand there. I hope we'll keep seeing more people get vaccinated, but that'll still be very accessible because it will be also available throughout all of our primary care offices. And so you'll be able to easily find one. And of course, you can go to any drugstore, walk in right now and find a vaccine if you're ready to get a vaccine. So with that, I will wrap things up and really appreciate each of your time here today. I do think there's a couple of questions that have come in. I'm kind of trying to look them over there, and basically I think I've pretty much answered them, which is, are we still going to offer them at all our hospitals? We're not going to have those high volume vaccine sites anymore coming across our hospitals because it doesn't make sense. There's just not enough demand right now, not enough people coming in. But if we need to stage them up, we will in a second, and we are going to run the Josie Roberts site, very actively. Then the question after that: do we have physicians who are writing prescriptions for a 4th vaccination based on age? This is somebody who says, I'm 73, I'm going to be traveling overseas this summer. Again, a discussion for you and your physician. I will tell you, I personally am writing prescriptions for my patients who either I talk with them and they're considered very high risk and it's been a number of months. I'd like to make sure their antibody levels are shored up. Certainly if you're going to do something, which hopefully you can, which is go go someplace this summer, and it's been by then, 6, 7, 8, 9 months, whatever it is, I think, the better part of caution would probably be doing that if you're at higher risk. I think the key message I'd like people to hear going forward, and I said this yesterday with a big group at the Greater Houston Partnership, this is turning out to potentially be one of the best times, if not the best time we've had during COVID. We're not quite there yet, but give it another 2-3 weeks with the numbers we're seeing come down, and I'm knocking a lot of wood as I say this. And so seize the moment, and seize the moment safely. So be logical, be cautious, adjust your risks and your behaviors based on your individual risk. I see a question about the rodeo. I mean, the rodeo's going on. We actually sent out a bunch of thoughts to our employees. Dr. Phillips did yesterday about how to maintain safety doing that, and it comes down to the same kinds of things. If you're really high risk, rodeo may not be the best idea for you, right? Being around all those people. If you're of average risk with the numbers we see and things keep coming down, there are ways to do that safely. We know how to do that, right? And we've been doing that throughout the pandemic, and we need to figure out that way to kind of, coexist with this virus safely. And frankly, as I said, seize this moment, because the thing we don't know, and anybody who tells you they do, is wrong. I mean, they're just selling you something or telling you something that they can't possibly know. We don't know if there will be another surge. We don't know if there'll be another variant. I'm cautiously optimistic that barring another variant, we'll see some seasonality, but we won't see these big spikes. But we don't know if there'll be another variant. It's quite possible. We saw that in 3 weeks, the world can change. And so my message is, seize the moment safely and be ready to pivot. What we've done a really lousy job as a society is pivoting when we need to pivot. When we saw what we saw the day after Thanksgiving, we should have said, okay, we can attenuate, we can bring down this peak, we can make it less bad, and actually it'll make it less long, and we can have a much ultimately better time of it. And we didn't do that, and we lost a lot of people and lost a lot of lives and disrupted ourselves actually more when it got peaked out than we would have otherwise, as you saw, companies and others unable to, field an employee base because they had so many people out. I get a question here about summer. It's an intriguing question. If you look at the dynamics, we've had a surge both summers, and the surge has been in the south where we're highly air conditioned. It's really hot, and most of us spend more time indoors, in July than we spend, the rest of the year, unlike most of the country, which is the exact opposite. And then most of the country, including us, then as things get cold and you stay indoors a little more over the winter, has a surge. It's an intriguing question. I don't think we know the answer to it. I do think we need to watch closely for that. And if we start to see that, again, we're going to want to pivot. I am hopeful and cautiously optimistic that barring another variant, we're talking small surges, not big, huge, out of control surges like we've been seeing, but a variant's distinctly possible. So again, seize the moment safely, be ready to pivot. And my plan is to talk very little about COVID and listen to the experts in these future conversations. So with that, I'll bring us to a close. I want to thank the members of the Methodist DeBakey Heart and Vascular Council. I want to thank the members of our Society for Leading Medicine. Robyn Canterbury, thank you for your leadership of our council. We've all expressed how important that council is and your leadership is, and so thank you very much for all of that. I want to thank our physicians here who've really supported us and given us a lot of great information today. We will see you, I believe it's March 24th, and we will be talking with some of our physician scientists and really talking about how philanthropy and many generous benefactors and supporters have really helped. We saw some of that just today, but have really helped propel much of the research and exciting things that are happening here at Houston Methodist. So thank you very much and have a great day.